all. So, oh yeah, sorry, just got a message recording being started. So, yeah, so essentially in my career, I've just been thrown around with so many things, then asked to do some of the projects that I had no idea what I'm doing, essentially. So, but that's what you get out of it, you know. We'll go through this. So let me just quickly share my screen, and hopefully we can get going from there. Are you able to see my screen now?
We can hear. Yeah.
Are you seeing a full screen?
Yes.
Beautiful.
Presentation.
Thank you. So Sumit Sharma, I'm currently the Senior Solutions Lead for ANZ and opening up to APAC as well for a company organization called Virtual Care. In layman language, in the public health sector, so-called join the dark side now, you know. So from my professional profile, yes, as I was highlighting, so more than 11 years in public health, went through emergency department as a system and business analyst, and they're going into theatre and anesthesia for the deployment of EPIC, electronic medical record at the Children's Hospital, and going through like inpatient projects, the community services, and some of the outpatient project, in fact, as well. I have had an opportunity to implement electronic medical record, both EPIC and EMR, across the Children's Hospital and the Alfred Health, and some of the projects aligned with the Cerner EMR implementation was actually about specimen collection project, anatomical pathology project. I remember when I joined Alfred Health, they said, hey, Sumit, we want to start with the anatomical pathology project out in the theatre. The first question I had to actually ask the lead, like, what the hell is anatomical pathology? Like, to me, when I hear about the pathology, it's to do something with the blood. They go, oh, no. Okay, so then I had to, and same person, I had to then deliver the entire project at the Alfred within the span of 2 months when I joined. This was one of the major, and I've actually got a little bit further information on the clinical alerts because I was saying maybe it could be pertinent to some of the projects you're doing. When I joined the Alfred, we had to revamp. There were some components of EMR used in ED and theatres, for example. We had to revamp all existing clinical alerts they were using for last 15 years into a new framework, and you can imagine the pain that we had to go through. And it was getting to the point, I'll go through in detail, a little bit in detail on that as well. So that was a clinical project in the alert. We got the specimen collection. This is Alfred Health is the first in the country where clinicians going out in the community at patients' home, they mimic the entire workflow exactly as if this is the bedside nurse in terms of collecting patient's blood, printing specimen labels, scanning the label, everything documented electronically. And I had the opportunity to lead that project as well. Printer renaming, something I actually suggested to the organization, then end up being my project because the existing naming convention in the printer was so convoluted that you wouldn't even know where did that printer just go to with the naming convention. So I actually basically proposed a naming convention which is a lot easier, and thankfully the CEO that I was asked to present to the steering committee, chaired by the CEO, he quite liked it. And then he just basically said, can you actually start getting onto it straight away? But yes, I had that luxury of leading that project. Telehealth, which is basically, thanks to COVID, I introduced it across to the community services and other pathology, and rollout of smart point of care device, which is quite unique. And again, Alfred was quite unique in this position that community nurses take a lot of stuff when visiting a patient. This single device can perform at least 5 or 6 different functions without needing to carry different stuff across. And then we actually ran a pilot, and I started off the first stage of this project as well. Device strategy, electronic journey board, and obviously remote patient monitoring. We'll go into further detail on remote patient monitoring as well. At a very high level, went from IT technical application support, you know, with the tech guy, nerd, thrown into the electronic medical records journey, and then going over to the digital health, and finally joined the dark side because I really wanted to see this through from the vendor perspective as well. So now I have joined Virtual Care, where we have solutions called Dartos Health and also the wound management platform. Now, just don't want to bore you with a lot of stuff that I did, but just some of the, I wanted to actually talk about the alerts because this was one of the major issues in the organization. A clinician would be sitting in ED as an ED consultant or ward clinician. Before they can open the patient record, there could be up to 5 different pop-up messages that he or she would be presented before he can get into the bloody record. Now, what that did quite clearly, clinicians actually lost the whole idea of alert. Basically, they saw this as a problem. They were like, yeah, just let me get into the record. And sometimes there was a critical alert sitting in there. They were just trying to ignore it because for the rightful things on a day-to-day, the amount of patients they were looking after and number of clicks per day, it was just too much. What I was asked to do, revamp all clinical alerts. So the governance is quite important, but very stringent policies that we had. And it was funny, you talk to any existing alerts, you go to the anesthesia team and they tell you, no, this is critical. You can't take it off, to the point that you talk to another team, they're like, that is critical. But it was a very lengthy process. We eventually structured under the tier structure. So each clinical alert was put into the category and that will be associated with the tier. So for example, the tier 1, the definition is the most serious life-threatening, if it required significant modification of clinical care, lifelong, chronic, for example, and evidence-based. What that did, when the alert will pop up, this is the only alert which will bring as a pop-up to the clinician when they're opening the patient chart. And tier 1 is the only category. And once the clinician has clicked on it and acknowledged it, it will not appear for another 16 hours. So if the clinician constantly going to the same patient record, is just not going to keep popping up for the patient. And once they've clicked OK, I think most of you are familiar with Cerner, for example, banner bar, it just always be there on the banner bar. And all those alerts, rather than have a separate window, will be consolidated in a single window pop-up. And these are some of the categories that I'm showing you in terms of allergies, extreme behavior is concerned, including the family violence, for example, all these things that were actually included in there. Now, this is tier 2. The difference is, obviously, it's not life-threatening, but this not come up as a pop-up message for the clinician. It will go straight to the banner bar and will be entered via the problem action. But these were some of the high-level categories that would deem fit in the tier 2. Same goes with the tier 3, but the main difference is tier 3 is based on what the clinician was doing at the point of time and what the relevance is. So for example, if I'm about to prescribe a medicine and a patient is actually listed as allergic to penicillin, it will bring up a message, well, hang on, this patient is listed as allergic to penicillin. Are you sure? Or I can still override, but that was very specific rather than just randomly bringing up the pop-up message. Tier 4 category we created was more like messages, abnormal pathology results, and all that kind of stuff will go into the message center. So these are the categories of massive work, but we were able to create a framework, but that framework wouldn't go anywhere without the actual kind of structure around it. And there was a very strong governance structure with the very strong committees around it just to verify any future requests. We started to get request left, right, and center in the organization after the project, but we really had to carefully analyze each of the requests. The other project that I would just want to quickly tell you, so Alfred at home, at the time, we were going through the transition, so-called, we were going through Alfred at home policy as well to see how we can bring and create a structure and say more and more patient can be actually taken care of in their own home. From IT/digital health point of view, basically I was the lead for all home-based care project, and I was looking at it from a technology perspective. The framework was about divided into 3 things: the patient, clinician, and what it means operationally. And in terms of the patient, who is our patient in terms of cohort? What are the key requirements and where exactly technology is going to fit in? Exact same thing applied to the clinician, and exact same feature was then applied to the operational. Once I had that framework, and apologies if it's just too much in terms of icon on your face, but it's important to highlight the remote patient monitoring at the top, for example, was one single aspect. When we talk about patient care as a holistic approach, there's a lot more than just remote patient monitoring. And that's where we actually created, I was asked to create a framework. So this is about remote patient monitoring and what it constitutes, what things we need to make sure are in place in order to avail remote patient monitoring. That's where the project came through for deploying the pilot for remote patient monitoring. And then telehealth, how do we embed a telehealth and what are some of the key things in the telehealth feature that we need to make use? As you can see, the bar, we were fairly, like almost everything to do with the telehealth, we were able to scale it up. And thanks to COVID as well to do that, to expedite the process. Clinician, I personally do see as a number of organizations that I've worked with, when it comes to the clinicians, the ability, we were actually already had a large footprint in terms of allowing the clinician or having that feature available for the clinician to do the live documentation whilst at patient's home, but we had to do a lot more work on that as well. And that's where this other project came through for the smart point of care. Last but definitely not least, everything is focused around patients. But when we talk about patients, when we talk about virtual care, the devices play a key role, your care plans and your symptom survey, also called as a patient questionnaire. I can now see the number of projects being run through in terms of providing virtual care to the patient based on some set of questions being sent through, getting the feedback from the question remotely and trying to assess where the patient is at a given time in their care. Very strong and profound way of providing care, and the patient portal, which is the Cerner patient portal. When we talk about on the right side, it's just the holistic, in order to provide that holistic approach, we can't just run it on our own as a hospital with just one entity. It had to be the combination of all those cares integrated into as one thing in order to provide that overall holistic care. Call me a nerd, yes. Now, but I have a quick video. It's an animated video. I had to trunk it down. I've actually presented at the project in the project directors, and then I was asked to present it to the executive committee chaired by the CIO at the Alfred Health, which I was doing this and going, I think she's just going to go, what the hell am I looking at? But they absolutely loved it. But I've truncated it, so you don't have to spend. It's under 2 minutes. I'm just going to play that. I just realized in Zoom, do I need to say that you hear the video as well when I'm sharing my screen? Of course. Hang on. Let me just quickly share my screen again. Share sound. Are you seeing my screen now again? Beautiful. Let's play it. Fingers crossed.
Hello, everyone.
Can you hear it?
We can hear sound. Yep.
Beautiful.
As you probably already be aware that there's a fair bit of stuff happening in the IT space, but for today, just want to talk to a couple of our major achievements in our community project. So the first one that I'm going to talk to is the stage 1 of remote patient monitoring. And the second one that I will talk to is a smart Android-based point of care devices. We have commenced the stage 1 or the pilot of remote patient monitoring, where the suitable patient receives the monitoring device and the clinician uses a telehealth platform to consult the patient, and during the consultation, clinician also gathers the physiological readings from the patient. The aim of the pilot is to understand both clinician and patient's perspective on this emerging technology of remote monitoring. The second achievement is for our community nurses. And for that, let me introduce you to Alison. And Alison is about to visit one of our patients at home. At patient's home, along with medical equipment, Alison also carries a laptop for EMR documentation, Juris Alarm, a mobile phone, and a scanner for things like medication administration and specimen collection. We ran a trial with a couple of Android-based smart point-of-care devices, and after the tender process, we're going to use the Zebra device. Under our future roadmap, clinicians like Alison will be able to use a single device to perform multiple functions, from Juris Alarm, inbuilt scanner, to running Cerner mobility solutions.
So when we talk about the stage 1 of remote patient monitoring, it's not that full-blown the pilot that I ran at the Alfred. This was before, one step before that. So the understanding was, let's get some monitoring devices like your pulse oximeter, blood pressure machine devices, your thermometer, scales, all that kind of stuff, and introduce along with the telehealth and see exactly what the experience is from the patient's perspective and the clinician's perspective. Are we really adding a value? Now, the point that I want to note here, it's the team that I actually approached. It's called Better at Home, also previously known as a GenMed at Home, one of the community services. Excuse me. At first, I was told, no, our patients are quite old, just not going to fit well. Probably this technology and this device is not going to add any value. After having further discussions, they said, yes, let's start it. Now, it's actually the best outcome that I could ever ask for. Very single first patient that they actually introduced this telehealth and devices along with it. It came through this as an email. This patient, very first patient they introduced these devices as well, reported that how easy to use and, well as the healthcare direct platform, this patient required multiple therapists to visit. And this, by the end of it, this patient was too tired even to start the process. And they were able to do that by every second day visit. Now that's quite profound. Imagine the nursing, which is the biggest thing as a workforce, don't have to travel that patient every single day. It's every second day. So you're saving the clinician's time. And also better experience for the patient as well. And you're still not compromising the care, the optimal care that you do want to provide to your patient. Now, it was the same patient who actually during COVID days, they wanted to visit her partner's home, which was outside of the Melbourne. The geographical location is quite a big thing when it comes to providing care, both from financial perspective in terms of funding and also ability to go and visit the patient. Because the patient was on virtual under the devices as well, there's monitoring devices, they were able to allow the patient to go and visit his partner's house and all that kind of stuff and still receive that close monitoring that he needed. And amazing how patient that actually wanted to put that as a comment, that it just really profound experience on his side. To us, it's a big thing. So again, I think it's important. You're in such a good position as a digital health ambassadors. You may sometimes from the first go may get a pushback, but sometimes it's just the unknown. The service, the given service, the organization may not actually realize the benefit until they start to embed it, implement it. It's the same service we were actually saying no. I started asking me, can we have actually some iPads as well? Because some patients don't even have a phone. And they started giving an iPad and they became the real super users for this kind of platforms as well. Remote patient monitoring, so that was using a Philips system. At the time, we actually did the market sounding. Basically, we used the hospital admission risk program as a service, a HARP service, targeting heart failure. And there was a lot of stuff, as you can imagine, needed to be done in terms of ethics approval, market sounding. There was internal NPTI, which is new product for trial introduction, that makes sure from OHN's perspective, from infection prevention and biomedical engineering perspective, all these devices are safe to use. And we had to specifically create a guideline talking about duration, onboarding, offboarding process, nursing responsibilities. Nursing staff need clear-cut A to B, exactly what they're supposed to do and what the escalation pathways are. The documentation strategy and cleaning, all those things had to be embedded as a specific guideline. At a very high level, so the idea was that these are the devices will be given to the patient, because this is a heart failure patient cohort we're talking about, along with the tablet. And on the other side, the patient will use the tablet and the devices. And on the right side, the clinicians will have this comprehensive dashboard, which again, as a vendor, we do as well as a Datos, that's the remote patient monitoring program that we do provides that care. And we ran the pilot over 6 months. Very strong. And again, I'm sure you're aware, but it just needs to, with any project, strong governance is the must that you have to have in order to make sure the project is actually hitting goals and it is actually being aligned. Obviously, with any project, there's always a challenge. Change is always a big thing. Incorporating technology, nobody likes change, and change aspect is something we have to work with to understand what the pain points are. And understanding the given technology, how would that fit and streamline the existing model of care? That's where you guys come in, by the way. unknown territory. Sometimes it's just unknown. Even you don't know how's that going to play around, and proof of concept is the only option to go with it. There was some inbuilt in the organization, the process that you have to go through that may not even have envisaged, but something that you will have to go through. And NPTI was a very painful task. Thanks to infection, I have a lot of respect for infection prevention people, but gee, that was a lot of work too when we had to work with them. And end user perspective. So it's just that you need to sometimes understand, put the foot in their shoe to under what they are trying to project in terms of it, not necessarily the constantly winning. It's about sometimes it's really like important points. You can't get any project underway unless you speak to their pain points. So really crucial. Otherwise, you can go in there and give the presentation about 20 new things that they can use, but if it doesn't address the pain points, we're not going to be able to get anywhere or have their buy-in. Opportunities for you. As a digital health ambassadors, you are in a prime position because you understand the current technology and what's available, and that's what you're going through in the Melbourne Uni course as well. And that will allow you to foresee the benefit, and not only the benefits, but the limitations as well on the given technology. There's a wealth of knowledge you're going to acquire, especially around the data side of as well. You know, there's a physical, that project life cycle is about scoping, the understanding the critical data points, and not only that, how we're going to then capture the data and leverage it to provide better care. Really crucial, and I'm so glad that you actually went through going through the same process as well. It helped me a lot applying those principles in the real life when I was working. Understanding the current model of care, nobody can understand more because you are at the operational level as well. You would understand exactly how the given technology is going to fit in and whether that's going to streamline the current workflows. There is a lot of gap when it comes to IT people talking to the clinicians and the clinician trying to project the information back to IT people. As a conjurant, you understand, you will have an understanding of both technological or technical. You don't need to be sitting in there and doing the coding, but at least enough to understand and relay the language back to the clinician and understand the clinician's point of view and have that really optimal care of providing project and really getting to the success. This is basically the slide deck that I wanted to present, but please, I will open up for any questions you may have. But that's pretty much that I wanted to share with you in terms of the slide deck today. I'll unshare my screen now as well.
Thank you so much, Sumit. I'm sure we got lots of questions. It's just really great to talk to someone who's been on the ground and developed and implemented so many projects that are relevant to this group. If the fellows, if you have a question,